Hello, everyone. I hope you're all having a wonderful day. My name is Luqman Siddiq, and I'm the coordinator of Alfaisal MedHub under the International Office at Alfaisal University in Riyadh, Saudi Arabia. I'd like to welcome you all to a webinar under the Career Guidance Series, United States Fellowship Track, and I'm honored to be your host for today. For those of you who don't know what Alfaisal MedHub is, it's an initiative under the umbrella of the International Office, College of Medicine, that aims at creating an online global community of medical students. Alfaisal MedHub covers a broad range of topics that are common to medical students all around the world, and the Career Guidance series and podcasts are its main initiatives. Our primary objective here at Alfaisal MedHub is to help medical students learn more about the career opportunities available after graduating, as well as the steps involved in pursuing them. Since medical students are usually confused about the path that's ahead of them, Alfaisal MedHub's Career Guidance series addresses this challenge from the perspective of accomplished and experienced seniors. Please allow me to introduce to you our speaker for today, Dr. Naief, who will be delivering the webinar titled Pursuing Nephrology Fellowship Training. Dr. Naief graduated from the College of Medicine at Alfaisal University in 2017. He completed his internal medicine residency at the Brooklyn Hospital Center in Brooklyn, New York, and is certified by the American Board of International Medicine. Dr. Naief is currently a PGY5 nephrology fellow at Vanderbilt University Medical Center in Nashville, Tennessee. After completing his fellowship, he plans on working as a private practice nephrologist in Phoenix, Arizona. His favorite part of the nephron is the proximal tubule because it does most of the work. Thank you so much for joining us today, Dr. Naief. We are looking forward to this webinar.
I do want to start by talking about disclosures. I have no pertinent financial disclosures. I do want to disclose that my opinions are my own. None of what I discuss today, none of the ideas or what I'm about to present is endorsed or shared or supported by my current or former employers. Everything I'm about to talk to comes from my personal perspective as a former nephrology fellow. So this is basically going to be the outline of my presentation. I'll be starting out by telling you a little bit about me and my background. Then I'll move on to try to convince you, my audience, on the many reasons why you should choose nephrology as your future career and why it's the true specialty of choice. I'll be telling you about reasons why not to choose nephrology, how to best prepare your application, finding the right program for you and what to look out for when you're choosing a nephrology fellowship program, and the various nephrology career paths after fellowship, because not all of it is just clinical medicine. So I graduated from Alfaisal in 2017. I spent about a year trying to prepare my application, finish up my USMLEs, working as a TA, and briefly as a service resident in Riyadh. In 2018, that is when I matched at the Brooklyn Hospital Center in internal medicine. 2019, COVID happened. It was not a great sort of time, specifically early of 2020. I graduated internal medicine in 2021. I did my boards in August and felt in the US. I don't know how many of you guys are already in the system or are going into the system, but you typically take your board certification exams a couple of months after you graduate. So for people who are in internal medicine residency, boards are typically in August. For people who are in subspecialty exams are typically in November or December. So I was really, really lucky and fortunate to have matched at Vanderbilt University Medical Center for my fellowship, where I spent the last 2 years of my life. And hopefully on July 24th, I'll be starting my permanent job as a private practice nephrologist in Phoenix, Arizona. So why nephrology? I think really nephrology is a great field and you should consider it if you're interested in physiology. So I really think you should consider nephrology if you're interested in physiology. If you love medicine, I feel like nephrology is really just an extension of medicine in general. And if you really, really love internal medicine, nephrology would be a great career path for you. If you're interested in learning about extracorporeal therapies like dialysis, and if you really like managing a sick patient population, because you have to keep in mind, the typical nephrology patient is on, something like 8 medications, has many comorbidities, and is someone that's dealing with what's essentially organ failure. And you have to keep that in mind whenever you see a patient with end-stage kidney disease or really advanced chronic kidney disease. I think it's great if you like variety. So a lot of specialties, I don't feel like it has the variety nephrology has. You have your inpatient consults, which can be anything from the typical med-surg floor patient to critically ill patients in the ICU. And there's a lot of variety in those inpatient consults, as I'm about to talk about later. You also get your continuity of care. You get to really know your patients over time in your outpatient CKD clinic. You also get to know your patients when you see them on dialysis. So the typical schedule is, although patients are getting dialysis 3 days a week, either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, and in-center, you see them around once a week if you're a nephrologist rounding in a dialysis unit, either you or one of your partners. Also, lots of patients nowadays, there's this huge push towards getting people on a home dialysis modality. So you don't actually have to round to a dialysis unit to see your dialysis patients. You can actually see them in clinic and help manage their prescription and change things there. One last thing that I do want to talk about in regards to nephrology is job availability and security. I think this is huge and something you should really, really consider when you're looking for a subspecialty. The more subspecialized you get, the harder it is to get a job. The more niche and more sort of resources required for you to do your job and career, the harder it is to find a job in a desired area. And this is particularly true if you are on a visa. Me being myself on a J1 visa, I had to go through the J1 visa waiver process, and I'm happy to talk about that with anyone who's interested in it individually later. So chronic kidney disease, it's estimated that about 1 in 7 people in the United States have some element of chronic kidney disease. That's a lot of patients. That's about 36.5 million people. And if you want to look at things visually, this is data from the USRDS, where they tried to estimate the prevalence of chronic kidney disease amongst the American population. And as you can see, a lot of people have kidney disease, and anyone in orange or in red is at high risk of developing end-stage renal disease or requiring dialysis. So there's definitely a huge need for nephrologists, not because of just managing patients with end-stage renal disease, but also from a preventative aspect, help preserve as much kidney function as possible. It looks like a linear line. Patients with, or people with end-stage kidney disease forever growing, and 2019 COVID-19 happened. Can anyone guess why there was like this sort of plateau? Okay, so the reason is because a lot of dialysis patients were the most susceptible to dying from COVID-19, and probably the reason why the prevalence of people with end-stage kidney disease plateaued and didn't grow was because a lot of people with end-stage kidney disease ended up dying. That's my interpretation of the data, at least. So this is other important data. As you can see, not all patients with end-stage kidney disease means that they're on dialysis. If you take a look at the green line, there's an ever-growing kidney transplant population in the United States. And not all of those patients are being managed by a transplant nephrologist. A lot of those patients eventually, 1 year out, 5 years out, they don't need to see a transplant nephrologist anymore. They're being managed by a general nephrologist. So I think the big picture is patients, it seems like there is a high prevalence of chronic kidney disease, and there's a growing end-stage kidney disease population who need a large amount of physicians to help take care of them. And if you look online, there are a lot of jobs available. So this is just from the American Society of Nephrology. And looking at jobs related to nephrology, there are 326 available jobs. which is plenty for this time of year. And this is not even looking at practices that aren't advertising and other websites more catered towards private practice nephrologists like PracticeLink or PracticeMatch. There are jobs for nephrology available in almost every major city. So that's another reason why you should definitely consider the field, because we are in desperate need of more nephrologists. So why not nephrology? One of the things that I didn't realize about nephrology is the commuting. Nephrology requires a lot of commuting, and the Americans have a term for it. They call it windshield time. So that's time that's spent unaccounted for where you're going from one place to another. And unlike most fields, nephrology might have a significant amount of windshield time, accounting for the time spent going from places like the hospital to your outpatient clinic if it's located somewhere else, to the dialysis unit, which is definitely located somewhere else, to places like, for example, rehabilitation centers. It's really rare to find a job where you're working at one hospital and the dialysis unit that's outpatient is attached to that particular hospital. That being said, there's a lot of job availability and demand, so everything's negotiable. I've seen a lot of jobs out there where it's outpatient only and all they do is clinic. There are rare jobs out there where you only do dialysis rounding. There are jobs out there where it's nephro-hospitalist, so you do 1 week on, 1 week off of consults. The one thing that you shouldn't think about choosing nephrology for is if you're thinking of it as a pathway to the US to do medicine. I think it's very risky. And the reason I think it's risky is because the competitive programs tend to remain competitive, and the positions that go unfilled are often possibly desperate to take candidates, and may take candidates that haven't gone through internal medicine residency in the United States through an ACGME accredited program. The reason it's so important to graduate from an ACGME accredited program is because without it, you're unable to sit for your board certification exams. So you need to have your ABIM first before you can subspecialize in something like nephrology, gastroenterology, cardiology, and so on and so forth. It's also really difficult to get an independent license if you're planning on practicing into the US with only 2 years of fellowship, because most places would require you to have at least 3 years of postgraduate medical education as a foreign medical graduate before you can get an independent state license to treat patients. I also think that you should really avoid nephrology if you don't like being busy. Throughout fellowship, I can probably count on one hand the number of nights where I've gotten more than 4 hours of sleep while I was on call. I want you to forget for a moment the patients who are ESRD and dialysis dependent, and patients who are in need of urgent dialysis overnight. Think about what people can call you for, and that's really nearly anything that you can think of that flags as abnormal on a BMP can lead to a nephrology consult. So you'll be called about things like hyper and hyponatremia, hypo and hyperkalemia, hypomagnesemia, hyper and hypocalcemia, hypo and hyperphosphatemia, metabolic acidosis, and alkalosis. You get the picture. People will call you for an elevated BUN. You'll even, you're not even safe from urinalyses. People will reach out to you to help evaluate things like hematuria and proteinuria. So whatever that pops as abnormal on a BMP, probably in everything except hyper and hypoglycemia can essentially lead to nephrology consults. And clinically, you'll get called a lot. You'll get called a lot about helping manage difficult to treat hypertension. You'll get called about fluid management. You're often the first person people will reach out to when there are issues with dialysis access. So as a nephrologist, you'll have to triage if it's something that you can manage alone, something like TPAing a catheter, or if it's something that will require interventional radiology or surgical intervention. Clinically, you'll even get called about things like polyuria. You'll get called about help managing renal transplant recipient immunosuppression. You'll get called about fluid overload and heart failure patients. Even cardiologists are going to be reaching out to you to help manage their patients with diuretic resistance. I think, I'm belaboring this point, but nephrology is generally considered a very busy field. And lastly, finances. I think financially, it's an important aspect of why you choose what you do. And nephrology, although it's better paid than internal medicine, is usually associated with delayed financial compensation. So this is data from Medscape in 2022, and I do want to preface this by saying that this data is nearly meaningless, and the reason because of that is because intra-specialty variation is usually far greater than inter-specialty variation in terms of compensation. So what does that mean? It means that the range of what you can make in a particular specialty can usually overcome the specialty difference. There are people in primary care who are exceeding plastic surgery salaries, and there are people who are doing cardiology who are getting paid far less, depending on what sort of contract they accept. That being said, based on this data, nephrologists on average make about $65,000 more than internists a year. So assuming a fellow salary of $70,000, it will take you about 6 years to break even if you make the mean reported nephrology salary. 6 years to break even being that you spent 2 years in fellowship, where you could have been making a lot more money instead. That being said, most people who do start out in nephrology do not start out making the average salary. They tend to start out making below average salary, and part of that is all the costs associated with establishing a new practice, getting patients, growing your patient base. So if none of what I said just deterred you, then that's great. I think you'll be very happy with nephrology as a career. And here are all the things you should look out for in a program. I think, first and foremost, you want to get exposed to all renal replacement modalities possible. By the end of fellowship, you need to have a very strong understanding of dialysis physiology and feel comfortable prescribing intermittent hemodialysis, isolated or pure ultrafiltration, sustained low efficiency dialysis. You need to be able to do all forms of continuous renal replacement therapy, whether it's continuous veno-venous hemodialysis or hemodiafiltration, or even just slow continuous ultrafiltration. The reason is you don't know what particular institute you're going to end up in and what their practice patterns are. So you want to be very comfortable with really everything. The program you're looking at also really needs to have a large peritoneal dialysis population. I feel like it's absolutely essential to have graduated fellowship being very comfortable managing peritoneal dialysis and peritoneal dialysis related complications, things like exit site and tunnel infections, PD related peritonitis, PD catheter related dysfunction. And I think it's always a bonus if you have a program that has urgent start PD, where they start peritoneal dialysis acutely instead of hemodialysis in the hospital. Lastly, you need to be able to manage someone on home hemodialysis. I feel like where I went to fellowship, we had great exposure to all of the above. The only two types of patients I wasn't exposed to in fellowship were folks on nocturnal home hemodialysis and folks on nocturnal in-center hemodialysis, which also exist. Another thing you should look out for is nephrology ownership of apheresis. So most programs defer apheresis to hematopathology. And I think that nephrology ownership of apheresis is a huge boon to a fellowship program. Being able to perform therapeutic plasma exchange, manage and understand its complications really feels invaluable. It adds to your skill set and makes you far more marketable. And if you end up at a smaller program post-fellowship without apheresis, you could help establish it there. Plasma exchange, it's also a cornerstone therapy for a number of nephrology diseases, things like anti-GBM, select cases of ANCA-associated vasculitis, if you're treating a renal transplant recipient with antibody-mediated rejection, All of these require plasma exchange as cornerstone of its therapy, and you could also offer the procedure to other services. So you help manage things like TTP, neuromyelitis optica, myasthenia gravis, or optic neuritis flares, or even other organ rejection. So suddenly, instead of transferring out a huge number of patients to a bigger center, you can manage them at your center. Being able to do other forms of apheresis, like LDL apheresis. These are for patients with familial hypertriglyceridemia. Learning that's also helpful. Leukoreduction, I put plus or minus because I had to perform it about 7 or 8 times in my fellowship. And personally, I'd much rather hematology manage it. I haven't really done platelet pheresis for thrombocytosis or red cell exchange for something like sickle cell crisis, because in most places that typically falls under a hematologist's umbrella. You do need a large kidney transplant population. And before I move on, I just want to move back to the slide. Remember, the kidney transplant population is ever growing. There's not nearly enough renal transplant physicians to meet the growing demand of their kidney transplant recipients' needs. And generally, you'll need a general nephrologist to help co-manage things. And at many, if not most places, what they do is shared management between the transplant nephrologist and the general nephrologist, with alternating visits. And at some places, old kidney transplant recipients, so patients more than 5 years out or so, or as little as 1 year, can be managed entirely by the general nephrologist. So finding a fellowship with a huge kidney transplant population is essential, because you need to be comfortable titrating immunosuppression, know their drug-drug interactions, and be able to deal with and identify transplant-related complications. I also think it's important to be at a large referral center. You want to be at that quaternary or tertiary hospital that gets all the cases. That way you have the opportunity to see and manage all the rare pathology during fellowship, so you don't just first encounter it when you're in attending on your own. You don't want your first patient with posse-immune GN or treatment-resistant C3GN to be when you're on your own. You don't want to be dealing with a patient who is pregnant and on dialysis and be thinking, what do I do now? How do I adjust their dialysis schedule? You'd want to have done it before, during training. I feel like working at a center with multiple subspecialty ICUs is also huge and will add to your repertoire of managing critically ill patients. And through experiential learning through fellowship, you'll learn so much without even realizing you're learning. So if your institute has things like ECMO, you'll learn how to splice the CRT circuit into the ECMO circuit. So the ECMO circuit in that situation would act like your access, and you'd avoid things like dialysis catheter placement. If you have a strong cardiac ICU with patients like LVADs, you'll know how to dialyze someone without a pulse, essentially, or a blood pressure as outpatient. If you have a neuro ICU, you'll learn about how to dialyze someone safely whose brain is herniating, or at least as safely as possible in that sort of situation. I do think also a strong renal pathology program is essential. Glomerulonephritis is difficult to manage, and having strong renal pathology in a large GN population is very helpful. And I also think going to a place with a procedure team is essential too. As you can imagine, you get called a lot as a nephrologist, and the last thing you want to worry about in the middle of the night or during the day as you're seeing your 12 to 20 patients in the morning and have clinic in the afternoon is placing a dialysis catheter for someone who needs emergent dialysis. So post-fellowship, what now? There's a lot of options post-fellowship. You can decide to do further postgraduate training. So you can do transplant nephrology, which is usually an additional year. You can do nephrology critical care, which is a combined 3-year fellowship. Some places like my program are offering a dialysis fellowship. Usually it's catered more towards people who don't have a strong home dialysis experience as our program does. So it give them an opportunity to learn about peritoneal dialysis and home hemodialysis. There are things like GN fellowships out there. Some people do interventional nephrology. They decide that they don't like seeing patients in the clinic or would like a mix of procedures and nephrology consults. The interventional nephrologists that I know all do interventional full time. So all they do are procedures. And there's a growing sort of armamentum and options of access options available and procedures available to interventional nephrologists. Like they're doing ultrasound guided access creations while the patients are awake, endovascular AV fistulas, essentially, without the need for general anesthesia, with nearly comparable results to surgical AVFs. Also, patients with kidney disease, as I said, are generally very sick. So there are fellowships out there where there's combined nephrology and palliative care. There's onconephrology. Chemotherapies and cancer can do really strange things to the kidney, so much so that it's developed its own fellowship, which is also an additional year. There are a number of career options available after you're done with fellowship. Some people like research and want to become physician scientists. That typically requires a really strong research background, additional research years, things like a master's or a PhD, but it's definitely doable. If you want to work in an academic sort of environment, you can become a clinician educator and work with residents. You could be hospital employed. You could work in private practice, or you could work in industry completely unrelated to clinical care, like pharmaceuticals or consulting. One thing that's really important to know, I feel like, for a lot of us is being on a J1 and the J1 waiver process. I think that's beyond the scope of this talk. So feel free to contact me either by cell phone, on WhatsApp, shoot me a text, or send me an email if you're interested in learning more about this process. Again, I'm not a lawyer, but having gone through this, I can give you my perspective of what I went through. So lastly, how to do your best and how to stand out in your fellowship application. I think the most important thing is do well now. Be an excellent resident, be an excellent resident, be an excellent resident, because that's going to determine your letters of recommendation. That's going to determine if you're at a program, whether they'll take you or not. Word of mouth and who you know goes a long way. Networking also goes a long way. So try to do LA rotations if you can. It might be problematic at certain hospitals because when you do an away rotation, you typically take your ECFMG funding with you to the outside hospital. But if possible, away rotations are invaluable. For people in residency right now or medical students, consider participating in ASN Kidney Week. Think about the ASN Kidney Stars program. There's a link in my presentation. They offer travel grants. So if you apply, you can have the cost of travel, your hotel, your booking, your fee for attending the conference fully reimbursed if you get this grant. And just try to publish an abstract at ASN. It's not that difficult. If you have an interesting case, you can reach out to me or whoever your attending is on service on that particular case and potentially write it up. It's a great way to help network in the nephrology community. So thank you for enduring my presentation. I apologize for all the disconnections. Does anyone have any particular specific questions they'd like to ask?
Thank you for the informative presentation, Dr. Naief. I'm sure everyone in the audience found it very beneficial. We truly value your experience and guidance. To everyone in the audience, thank you for joining us, and our team hopes that you found this session as informative as we did. If you have any more questions, please feel free to put them in the chat now, or you can unmute and ask your questions. Also, make sure to follow us on social media platforms and subscribe to our YouTube channel to receive the latest updates about all our upcoming events. The links have been pasted in the chat. If you have any further questions, again, do contact us in the future via the link to our website or via our number. Again, thank you to Dr. Naief and everyone in the audience, and we hope to see you in our future webinars. Have a wonderful rest of the day. Goodbye.